studied in Arizona, did travel PT for a little bit, and now I'm in New York at James Fowler. So I've been doing prenatal post since I was when I started, and that's been kind of the population I'm trying to hone in here in New York. So that's why we're offering this, to kind of get the word out there. Hey, I'm here and happy to help. So I know you are treating prenatal postpartum. How long have you been treating?
Maybe a couple months. Well, I mean, non-shelter in place. I've been doing some virtual, a couple virtual visits of women who are pregnant, mostly back pain, SI issues. At my previous job, I didn't really treat people who are pregnant and postpartum because we had a in-house pelvic floor therapist.
Right.
Um, but I'm just starting to treat the population. So I've probably treated 6.
Okay. Good.
Yeah, so, and they all, I think it's all been, no pelvic floor issues. It's all been back pain, SI issues. I guess I've been treating some postpartum, and they have a plethora of things, but mostly related to ergonomics.
Right. Okay, cool. So today what I wanted to do is kind of start with the anatomy first and foremost, and then move into a little bit more of like some of the things that we do in terms of posture and ergonomics. You already are doing some of the ergonomics. I'm not going to spend much time on that. But I do want to start off by bringing up my essential anatomy, which you're familiar with. So we're just looking at the general skeleton here. So make sure I'm on female, and we are.
It looks like it's kind of slid up a little bit.
Can you not see it?
No.
Okay, let me stop sharing for a moment and see what is going on here.
Stopping and starting again.
Could you see any of the human body?
I see like kind of the toolbar at the bottom, and it was halfway up the screen.
For some reason, it wasn't showing. It's not letting me show the whole thing, which is weird because it let me do a trial run. So let me just close it and open it for us. But you kind of know the general anatomy of, like, we have the transverse abdominis, which is deep to our oblique muscles and superficial to all of our organs, of course. And our transverse abdominis, have you taken any Herman and Wallace courses?
I have not yet.
Okay. So that is something that I would strongly recommend, even if it's just level 1. So I've done like the prenatal postpartum series, but level 1 is really good because I've noticed treating prenatal postpartum, if I don't have that internal component, I don't make as much progress with them. Even if they are presenting as truly orthopedic, just low back pain, SI joint, hip pain, whatever that may be. If I don't have that internal component going on, I just don't see as much progress oftentimes, or as quick.
Which includes doing an internal exam?
Correct. Yes. Okay. So I am a huge believer in internal examination, prenatal, postpartum. Now, obviously, there's some caveats. You can't always do an internal examination. Usually we don't do it within the first 6 weeks postpartum. And we don't do it in the first trimester because it's the most iffy trimester, right? Some therapists won't even do it in the second or third trimester. I say, you know what? People are having intercourse, which is a lot more vigorous than a digital examination. So I'm not so worried about it from a physiologic standpoint, right? So you just have to know your patient, right? Some people are going to be fully comfortable with it in the second, third trimester, and some people are not. And there has to be that trust, right? You have to know that they trust you and you trust them in order to go into that step. And there's a lot of external pelvic floor palpation that you can do and you can teach them to do as well. So those types of things, if you're leery to go internal and they're leery to go internal, we can always use, like, they can just put a finger on their rectum and do a pelvic floor contraction and relaxation and bulge. And then they can kind of feel themselves what's happening, and you can feel yourself what's happening there. Granted, it's more rectal than vaginal, and you're over the clothing, so you're not obviously going internal, but it gives you at least some tactile feedback. So this should work on the full screen now. Can you see the full thing?
Yeah.
Yay! Just gave me a little hiccup there. So I do want to look at the abdomen and just to kind of see all of the connections. So I want to take this muscle off, right? So this is our external oblique. So we're going to hide that. And then just deep to that is the internal oblique. We're going to hide that. And we have the rectus abdominis, our 6-pack abs, right? And we're going to take that away. This is our transverse abdominis. So it's deep, right? It's deep and it's like an internal corset. But if you see here, it also attaches at that inferior rib cage and really affects your diaphragm, right? Because your diaphragm and your rib cage are working together as well. So that transverse abdominis is going to fascially connect and have an effect also. And your diaphragm really connects into, let me hide some of these guys. Let me take some of this connective tissue off the digestive system. The diaphragm is really going to function directly with your pelvic floor. So what is your pelvic floor? I know if people might watch this later on and be like, Stephanie, you're talking to Sarah, you're both PTs, and what are you guys talking about, right? So this is your pelvic floor here, which is like a big bowl, right? It's your pelvis is a bowl. So all of these muscles in here, that's all pelvic floor muscles. And I'll show you a couple of more specific pictures in a minute, but I wanted you to see how those connect into, this is where part of our pelvis as well as is our pubic symphysis here. So all of that, those bones and these bones of your pelvis connect with this inguinal ligament, and all of the abdominal fascia connect into that, and a lot of the pelvic floor fascia connect into that as well. And that is a big area in pregnancy in particular that we're very interested in as physical therapists, because it gets a lot of pressure from the inside out from baby growing. So we oftentimes end up getting a lot of irritation in through these inguinal ligaments and through these hip flexors. So your hip flexors, everybody always mentions, and nobody really understands how deep they are. So that's another reason why I wanted to show just how deep they are. They're right on your spine, and they come right against your pelvis as well. So your hip flexors are really two big muscles. There's this muscle here, the iliacus, and then the psoas. So that's the psoas major. There's also a minor here. So really all three of them, right? These two are kind of the same muscle. They're just a little bit delineated. So all of those hip flexors are immediately right into your low back, but also they connect down into that pelvic floor. So you can see, Sarah, in particular, why your pregnant patients are going to be getting some of this pelvic pressure downward, but also getting a lot of lumbar pain. Oftentimes, from what I found from treating prenatal postpartum, is prenatal, you can't, like us physical therapists, we dig into this muscle, right? And we dig in right next to the belly button, right? We go from the belly button here, the umbilicus, and from the ASIS here, and we go right in the middle and we just dig right in, or we come right over the crest and dig right into this area here. You can't really do that on a pregnant woman, right? Because there's just too much risk. But there are a lot of other ways that we can at least fascially connect, and by getting some lumbar movement in, especially lumbar flexion and side bending. We also have a very broad, deep muscle here called the QL. If we get those lengthened or get some just mobility, gentle mobility into there, we can start to loosen up some of these fascial adhesions that can see. But it's a big part. I'm going to isolate it first in here so you guys can see what the diaphragm looks like. So the diaphragm is asymmetrical, right? We have a little smaller port left side, and so that all of our ladies, they're told on their left side. So as a practitioner, I pretty much always, unless there's some orthopedic SI joint, low back thing preventing them from going on their left side, 100% always with them lying on their left side, because they can't really go prone unless they're in their first trimester, which, let's be honest, they don't really have pain much in their first trimester. They get a lot of morning sickness, maybe not so much pain. And second trimester, they're starting to show. They don't really want to be going prone. I don't really want them going prone, because for the same reason we don't want to do abdominal binders, it just puts too much pressure. We don't really want abdominal bracing on this population, because it doesn't let baby move around. We need baby to move around. So it can lead to things like plagiocephaly, torticollis of the infant if we're constricting their mobility in the womb, right? So we don't want to do any binding for that, even though as therapists we're tempted to, because we're like, oh, we just need your abdomen to contract a little bit better. But we want to avoid that. So this diaphragm is atypically shaped, which is why we lie on the left side being pregnant. Postpartum, don't care, lie on either side, do you, right? But this frees up space. We lie on the left side, so now baby has more space to move around. Backs, because we have a structure called the inferior vena cava that comes straight down and through here and through this little hole, and baby will put too much pressure lying straight onto that inferior vena cava. So I wonder if I can show you that. I guess it wouldn't be, oh, hey, I can. So there's the abdominal aorta that comes down. Can't show you the inferior vena cava, I don't think. So, so we just want to be very careful of all those arteries that come down through there, okay, and all those structures. But I will be totally honest, I do have my prenatal patients lie on their back every now and then for things like bridges or lower trunk rotations with our knees side to side, or happy baby pose, right, where we're doing a hip stretch. So my general moms get freaked out a little bit by that, and I understand, I would too. So what I do to kind of calm their nerves there is I just let them know, hey, as long as you're not getting shortness of breath or a crazy rapid heartbeat, you're fine. Those are the symptoms that you're going to get if you're putting too much pressure on these vessels going down. So if you're not getting shortness of breath, your heart rate's not going crazy, I don't mind you being there for a couple minutes. It's not the end of the world, okay? And it's really not. So how do I bring you out of share mode? Just to show you some pictures of the pelvic floor. This is looking from the bottom up. So if you're like watching a woman give birth, this is the bottom up position. And then this is looking from the top down. So ceiling looking down into that pelvis. We call it a pelvic floor, but it's really not a floor. It's actually more of like a tunnel or a funnel even. And it kind of goes down more into this V shape than it does a flat shape. So if you see here, they depict it as more of just like this flat straight line, but it really kind of goes down and up. Do you have a question, Sarah?
I'm still just seeing the whole person.
Say that 1 second again.
I'm still just seeing, I don't know if you brought up a pelvic floor picture.
Oh, I did.
Okay.
And you can't see it. Okay, let me stop the share and retry.
Cool. I think I'm gonna do it. Yep, okay. There you go. Okay, cool.
Okay, yay. Thank you, Sarah. It was like I saw the hand. So yeah, so they depict it as more of like a hammock, which some people do describe it as a hammock, and you can, that's not bad. But it is more of like a V, right? It's really more of a funnel, and then it all collapses, and it should kind of move. Can you see me this time?
Mm-hmm.
It should, yeah, exactly. It should move up with the diaphragm and down with the diaphragm and then bulge, right? So it should, as we breathe, as we inhale, it actually relaxes and expands. And then as we exhale, it contracts and draws up. Inhale, relax, expand. Exhale, contract, draw up. It's usually the reverse than people think it would be, but that is kind of that relationship of this top-bottom effect of your diaphragm, your pelvic floor or your pelvic tunnel or funnel or whatever you want to call it. They move simultaneously up and down with each other. Now the bulge part of it, that's an important part too, right? Because when we're on the toilet, in terms of pelvic health, general pelvic health, we don't, for urinating, for defecating, either one, we don't want to be bearing down to push the things out, right? We sit on the toilet, we get our knees above our hips to really get the pelvis really relaxed. And then just a gentle downward pressure or relaxation, really, it ends up elongating, and then we can defecate or urinate or whatever you need to do, right? So, but our body needs to be able to contract appropriately and relax appropriately, just like our bicep muscle. If we can't contract all the way and relax all the way, if we're going to be stuck and we're not going to be able to move. So oftentimes pelvic floor can end up falling into one of two categories. It can end up going into this weakness category where it's not activated enough, or it can fall into this hypertonic or this tense state, right? And so obviously we want to be in the middle. We want to be able to contract fully and we want to be able to relax fully. So doing the pelvic floor evaluation, we look at how much can you contract? Yes, how strong is it? And how long can you hold it? And can you do quick and release, right? Because that all changes. You need to be able to do quick and release so you don't have an urge incontinence, but you need to be able to hold to be able to get to the toilet as well, right? So you need to be able to do both with your pelvic floor, both prenatal and postpartum. So that's my biggest thing that I tell all my prenatal ladies. I'm like, the reason, if you're comfortable and I'm comfortable, you're in your later stages. Usually I like it more toward the end of the second trimester because you're pretty safe at that point. If they're having intercourse, if they're not having intercourse, I will not do an internal examination. But that's when I'll do it, and I'll really assess, can they fully contract? How long can they do it? What's their endurance? What's their strength? Can they do quick contractions? But also, can they release it? And can they bear down? Because you need to be able to lengthen, right? To be able to contract. So that's kind of what I do. And I like to see that. That's why I really love to see women before they're pregnant, ideally, but if they're trying to get pregnant, that way we can get them into a very active mindset, because exercise has been shown to reduce gestational diabetes risk, to reduce miscarriage risk. It doesn't increase it, which a lot of people think it does. Now, this is for general population, other populations aside, right? It can decrease your fatigue throughout pregnancy, decrease your low back pain, reduces your baby's risk for being overweight or underweight, either while they're born and later in life, but it also can help your baby not get diabetes too, adult diabetes later in life. So there's a lot of pros to exercise during prenatal stage, but it's hard. One of the not risk factors, but one of the precautions with exercising prenatal is we want you to have established exercise before you're even pregnant, right? Because we can do so much more with you while you're pregnant if you were doing more before. Granted, that doesn't happen for everybody, and we can still do a ton with you, right? We can still do mobilizations, we can still do pain management, we can still teach about the pelvic floor and the diaphragm, get your breath working with your exercises, get your body recoordinated, do ergonomics, all these things, right? Prepare you, get your shoulders open, work on your posture so that you can hold your baby and breastfeed your baby, and not just carry on one hip all the time, but teach all of these techniques of how to keep your body safe while you're pregnant, while you're in labor and delivery, with different positions you can get into, but then also postpartum while you're healing from all of this. Because some people, they might have perfectly healthy pre-pregnancy, during pregnancy, labor, delivery, everything went beautifully, not a complication in the world, and they can start being slightly active at about 2 weeks, and that's fine and safe as long as they're able to walk without discomfort and they have no more fecal or urinary incontinence, which both should resolve within 2 weeks just on their own. I typically am breastfeeding. If people are choosing to breastfeed, that can speed up that recovery because it creates little comparison in the pelvic floor to help speed along that recovery, because you're bringing in more blood flow, you're bringing in more neurologic connections to the brain. Because us as women, sometimes we are not very connected to our pelvic floor, we're not very aware of it. And so getting that awareness just by, even if we're breastfeeding postpartum, getting that connection of our breath and our diaphragm, our pelvic floor as we're breastfeeding can actually speed along some of that recovery a little bit, right? So I did want to mention, I know Heather's about to give me a little 5-minute hand. I see you.
Actually had a question for you.
Oh, sure.
So how far in advance do you think someone should start seeing you before, like if they're trying to get pregnant?
As soon as they're trying to get pregnant. If they don't already have, especially if they don't have an established exercise program, right? If they're pretty well active and they're cruising along, by all means, you don't have to see me until you've learned that you're pregnant, and then we can talk about it. If they want to come beforehand, that's great, because I can test their strength. They're not pregnant, right? So I have really no precautions unless they have a UTI. I can do my internal examination. So if they're just, my caution with, if they're trying to get pregnant, I need to know that they know they're not pregnant before I do an internal evaluation, because I don't want to be like no risk for me being the cause of a miscarriage, but I don't want to even be a thought of a potential cause, right? So I need to know for 100% certainty, peed on the stick today, I'm negative. All right, let's do an internal evaluation, right? But by all means, if you are just thinking about getting pregnant, you know, for sure you're not, come in. I can test internally, strength, endurance, quick release, full stretch, all of that, everything. I can make sure there's no prolapse, because some people have a prolapse, which is their organs kind of coming down, because the pelvic floor really creates that hammock or that tunnel to hold all your organs up, right? And with that, if we engage, then it can all start to kind of sag down. And I want to know, for their sake, do you have a prolapse going in? Because that changes what we're going to be doing to prepare you for labor and delivery. That changes the position that I want you to be in for labor and delivery. That changes what we're going to do postpartum. It's going to change the whole thing, right? So ideally, as soon as you know that you're not pregnant and you're thinking about doing it, come in. We can get kind of your baseline measures, really what it is. Like I said, we can do that prenatally as well, but things get inhibited as soon as you're pregnant because your hormones completely change, everything changes, your heart rate increases, your body temperature increases, and it just creates a completely different environment for your muscles to be able to contract and relax and how things are relating to one another. So the sooner the better is kind of always the answer, because it will allow me then to help them through the process of pregnancy, labor, delivery, and then postpartum in their recovery, and how quickly they can get back to their normal life, right? Because everybody thinks that this urinary incontinence, pain with sex, or anything like that after delivery, 12 weeks after delivery, is normal. It's not normal. It really should resolve within the first couple weeks. By 6 weeks, typically you're proved to have intercourse, and there should not really be pain with that. If there is, then there might be some other things going on that we can assess for prolapse. We can assess for a diastasis recti, and you know, how many fingers is it? 1, 2, or 3? 1 is pretty normal. Anything above that, we want to really be looking at, especially if it's with low back or hip pain or SI pain, like Sarah's been seeing. I do check for diastasis prenatal postpartum, because like, I don't have children. I've never been pregnant. And I have a diastasis because I used to have constipation when I was a kid. And so they think from all that bearing down, it actually created a ripping in my diastasis. So you can get it from other causes besides pregnancy, which people also don't realize. So yeah, the sooner the better is my answer. It's a very long answer, but the sooner the better. Sarah, did you have any questions in particular? I didn't get to like half the things I wanted to talk about. I feel like I could do a whole series on this because I'll just gibber away.
Actually, I shared this to a few of my friends like an hour ago, and one of them already got back to me. She's like, I'm working, but if she's doing another, she's in San Francisco.
Perfect. We post, I think, Heather, are we posting these?
Yeah, so basically what we're going to do is I'm recording all of this, so if you don't mind your voice being in it, it's not going to be your face, it's just Stephanie's face. And basically what we're going to do is putting it on our YouTube channel as well as our Instagram and Facebook, just so people can continue to see it. And then it's also going to be a process that we're going to continue to do. This is our first week, so we're kind of just gauging times and what times work best for people and things of that sort. So definitely something we're going to continue, because these are programs that we're going to continuously build up with JFPT.
Yeah, cool. I have kind of a pelvic floor question with your opportunity to treat people before pregnancy and assess before, during, and after pregnancy. Have you been able to establish trends that you've seen with how the pelvic floor functions pre, during, and post? And is there any difference between that you found between C-section and vaginal delivery?
So,
long question.
Good question. Good question. I'm going to address the first one, and then by the time I'm done, I'm going to forget your second one. So keep it in mind and then re-ask me. So have I realized any trends in terms of what the pelvic floor has done in all different stages?
How it functions, like have you noticed, like, because you were talking about hormonal changes, temperature changes, just basically our whole environment is different for how our muscles are functioning. Have you noticed any trends in, you know, I'll assess somebody while they're trying and they have a good like strong muscular contraction, like 100% strength or 95% strength. And during pregnancy, I noticed like their strength and contraction goes down.
It's going to change with, so yes, typically the stronger you are to start, the stronger you are throughout, right? Which we would anticipate, and that has been true, right? Yes, there is some level of a weakening that occurs during pregnancy, but I don't, you know, as a therapist, right? It's not a true weakness. It's just a lack of integration, a lack of use, and a lack of ability to completely articulate with one another, right? Because if our muscle is already on a little bit of stretch because baby's there, then we're not going to be able to contract as well. So yeah, there's a little bit of a drop off in pregnancy in terms of strength and endurance, but I think that's really just like my clinical brain says it's because inflammatory factors can be a little bit higher as well, and that inflammation in the pelvis, because all of our vessels dilate as well, so because our blood flow increases like mad. So if our vessels are dilated and we have so many little vessels within our pelvis and big vessels within our pelvis, I find it almost creates like this, I hate to say it, like a congestive pelvic disorder, but it's not, right? It's just like a temporary like congestion in the pelvis because there's so much fluid and pressure on the lymphatic system and on the vessels. But it really hasn't been like drastic for the ones that I have been able to test like later in pregnancy versus early on. I shouldn't say early on, but pre, really not a drastic difference in how much they can contract, but definitely more effort. I will say the ones that I've been able to kind of see the course through prenatal through postpartum, the earlier that I see people, usually it's week 36 that they come in. It's like on the nose. They come in on week 36 and they say, I started having pain 2 weeks ago. So week 34 is the week. But it's consistent, like across the board. It was kind of funny for a while. It was like, I had like 3 in one day and I'm like, so you're week 36? Like, yeah, how'd you know? I'm like, just but the ones that I've been able to kind of see through the whole thing have had the least need for a C-section and have had easier deliveries because we go over things like perineal massage and positioning, and a lot of them were trying for natural birth. Some of them weren't trying for natural birth. They wanted a C-section, or they were on like, they already had a C-section, so their physician would only do C-section, you know, things of that sort. Everybody's birth plan is different, so you just kind of work with what their plan is. But what was your question about C-sections? You noticed something?
Kind of side note before. By the way, when is this supposed to end?
Oh, like 3 minutes ago, but I'm not worried about it.
Is it okay if we go over a few minutes?
We can go over a few minutes. Yeah, that's okay.
Yeah, I actually watched a video by a pelvic floor therapist where she was talking about how she works a lot with CrossFitters, and she thinks one of the issues that they might have is that they're so strong and so good at contracting, but they have trouble delivering because they don't know how to relax.
Yes, 100%. I wouldn't just isolate that to CrossFitters. CrossFitters are extremists, so I'm not surprised that happens with that population. 100%. And that doesn't, like I said at the beginning, there's the weakness side of it if there's a dysfunction going on, right? It could be it's too weak, we're not engaged, or it could be too spastic, but that wouldn't fall really under either category. That would fall under hypertonicity, really. Like they're just like, they're so toned and they haven't practiced that bulging, right? That's why I say it's important to not just be able to release, but to be able to stretch and expand. It's like your muscle guys that walk around and never stretch, right? That's what's happening in their pelvic floor. They're like, I can't touch my shoulders because there's too much, but also because I never stretch my triceps, right? So it's the same thing. They need to be able to learn that control of full contraction, full relaxation, and a full stretch, right? So that's one of the main things that I kind of start off with is just like day one pelvic floor, whether you're healthy or not. I'm teaching, I shouldn't say healthy, whether there's a dysfunction or not. I want you to be able to understand and feel and know what it means to fully contract to relax and to expand. And hold a mirror down there. What does it look like when that happens? Because our brain can, like, we can feel it kind of, but once we put a mirror there and can actually watch it happen, it's amazing what connects. Like, I've had women who are like, I don't understand what's going on down there, like contract, relax. We put a mirror there and they're like, oh, I get it. That's all I needed to do. Okay. That biofeedback really helps. And that's why I'm a big fan of I haven't used a ton of stimulation in my practice, largely because of the population that I see. I've used it with like elderly incontinence and things of that sort, but I mostly use the biofeedback for pelvic floor, not just the mirror. The mirror is like the basic go-to, right? But putting on like a biofeedback machine with the 3 leads, and you put it on either side of the rectum and just have them contract the pelvic floor, and it gives them a little reading of how much they're contracting and how much they're not contracting, if you will, and if they're fully relaxing. Mm-hmm. So that has been one of the tools that I find to be very helpful to have in your practices is the biofeedback, because I can sit there all day and be like, you know, digitally inserted and having them contract and relax and saying, okay, you're contracting the anterior or the front portion, but you're not contracting the posterior or the back portion. They're gonna be like, I don't know what you mean, like, right? So, but with the feedback, it kind of shows them like, hey, are you contracting? Are you relaxing? Especially postpartum. That's a big trauma that happens, whether it's vaginal or C-section. There's trauma occurring in the pelvis and in the organs. So I would recommend taking a visceral mobilization course. I took IPAs. I really liked that one. But it's getting into viscera or the guts, right? Getting into mobilize through here. It also includes mobilizing into the uterus and, you know, all of your organs. So I personally really liked that class because it helps, everything kind of adheres. Whenever blood vessels break, tissues start to adhere to each other. Minute scar tissue forms and we create an adhesion, right? And so that's what visceral mobilization is doing, is it's breaking up those tiny adhesions so that things can slide and glide over each other again, which is huge postpartum because everything has been growing and then it suddenly is gone, right? And you leave this big void, and all these tiny little blood vessels have in the process bled naturally, and that creates a ton of little adhesions. I have not met a single postpartum woman, whether they have symptoms or not, that haven't had adhesions that I can easily palpate in their abdomen that they did not even realize were there, but were seeing me for like low back pain or SI pain or hip pain. And I'm like, and it's like 3 years later, and I'm like, oh, did you have babies? And they're like, yeah. And I start feeling around, and usually I feel a diastasis. Usually I feel a ton of lateral adhesions. So, say that again.
Which makes sense, coupled with you're stretched in the middle and you're getting pulled on the sides.
Right. One of my saving graces actually for diastasis, I've done like some of the KT taping across, which I think helps. They say research has shown 6 to 12 weeks is when you're going to get the most benefit from that KT tape for diastasis. But I do it regardless because I'm like, yeah, that's when you get the best result. But it's like 3 minutes of taping. It's worth it, right? You may as well do it. But yeah. I really like this. Whoops.
So it's like a cupping?
It's like cupping, but it's suction. So of course, like during prenatal, cupping is contraindicated because of clotting factor. So, and obviously you don't want to like be detaching anything. If you're doing it on the abdomen, we don't want to do it on the abdomen. I still don't do this on the abdomen. Forgive the visual, you're going to see my belly. But I usually go right on the side here, postpartum, right? On the side. And definitely through thoracolumbar. Like I go crazy on thoracolumbar and have them move and bend and child's pose left, child's pose right. And with that on, you could do regular cupping. I just like suction because I find it's a silicone suction. It's super cheap on Amazon for like $15 or something. And then they can get it and they can have their husband do it at home, or boyfriend or wife or whoever they have, right? Not the baby can't do it, but I like it because it's something easy. And I have noticed that diastasis close. Once I started using this in addition to the tape, I started to notice the speed up quite a bit more. The hardest part I found postpartum, if you start treating postpartum versus prenatal. Have you done postpartum? You've done postpartum. Yeah. The hardest thing I find is that women want their diastasis, if they have it, to go down to 0. And they're like, I'm not cured until I have 0. And that's just not realistic. One finger width, right? Being able to stick one finger all the way down is normal. And I don't ever expect it to be less than that. And trying to get some of our CrossFitters or people that are in like figure competitions, they don't want that, and that becomes more of a cosmetic barrier. And so it becomes more of a difficult conversation to have of like, well, really anything less than a 1 is not realistic at this, not even at this point, but just in general. And it's not medically necessary. And sometimes diastasis is there and it's not medically necessary to treat because they don't have any symptoms at all.
Yeah.
So now I would still treat it if it was like 2 fingers. I would still treat it personally, because the minimum that I really am okay with is like 1.5 typically. Anything above that, I still see some level of symptoms, even if it's just like sometimes my left SI gets irritated kind of a thing. Mm-hmm. I can still correlate that back to the diastasis, because those oblique muscles, the transverse abdominis, everything inserts right into that. And so if that lining is disrupted, the muscles aren't going to be able to properly support either. Mm-hmm. So anyways, I get on a lot of soapbox. Any other questions you have, Sarah?
I mean, I this could continue for hours.
I know.
We need to cut ourselves off. If you have a patient or something, but this is really interesting. Yeah, I think like even breaking this up into like even smaller bits or something, because there's so much to talk about with all of this, and I could see this being really helpful. Especially with doing it virtual. I'm sure people that need this information that might want to physically go in are hesitant. So, empower them to have this kind of platform and information. So this is cool.
I'm so glad you could join us, Sarah.
Yeah.
And like you said, it should be recorded. So if your friends, they were working and they want to watch it, you could always, once it's posted, I'll send you the link, Sarah. And then you can send it out to whoever you want. Okay.
Thanks so much.